Here's the full 15-minute script from a completely different angle, a patient POV investigative angle, where the narrator is a retired professional who almost lost their independence because of a medication nobody reviewed. I want to tell you something that took me 4 years, 3 doctors, and one very bad morning on my kitchen floor to finally understand. I'm not a physician. I'm not going to pretend I have medical training. What I have is a story, and I have the notes I took at every appointment for the last 6 years, and I have the research I did after I realized that nobody, not my cardiologist, not my internist, not my GP, had ever looked at my medications as a complete picture. They each looked at their piece. Nobody looked at the whole patient. I'm 74. I take blood pressure medication. And for years I thought that was a simple, managed part of my life. You have a number. The medication brings the number down. Done. That's what I was told. That's what most people are told. Here's what nobody told me. Blood pressure in a 74-year-old body is not the same biological problem as blood pressure in a 45-year-old body. The numbers on the machine can look identical. The mechanism underneath is completely different. And if the medication you're taking was designed around one mechanism, and your body is now operating on a different one, which happens as you age, that mismatch can produce effects that nobody will connect to your medication unless they're specifically looking for it. I didn't know that. I didn't know that for years. What I knew was that I was tired in a way that felt different from normal tired. I knew that mornings had started to feel dangerous. I knew that I'd stopped trusting myself on stairs after about 9 in the morning, which sounds specific because it was specific. I had figured out, through trial and error, that there was a window of time every morning where I didn't feel stable on my feet. I hadn't connected that to my medication. I connected it to being 72 at the time, then 73, then 74. I connected it to aging. My doctor briefly mentioned it might be inner ear. We did some tests. Nothing came back. The medication never came up. I want to walk you through what I eventually learned, because I think if you're over 65 and you're taking Amlodipine, Losartan, or Lisinopril, which between them represent a very large percentage of everyone taking blood pressure medication in this age range, some of this will be information you've never been given. Not because your doctors are careless, but because there's a gap between what the research says and what makes it into a 12-minute appointment that was mostly about something else. The first thing I learned, and I want to be precise here because this is the piece that changed how I understood everything else, is what happens to arteries as they age. When you're young, your arteries are elastic. When your heart pumps, the walls of the artery stretch slightly to absorb that pressure wave, then push back, which keeps blood moving smoothly between heartbeats. That elasticity is doing quiet, constant work to buffer the force your heart is generating. After decades, that elasticity decreases. The walls stiffen. When your heart pumps now, the artery can't absorb the wave the same way. The pressure registers higher and sharper. This is called arterial stiffness, and after 60, it becomes the dominant mechanism behind high blood pressure in most people, not the hormonal and kidney-related pathways that drive blood pressure in younger adults. Why does this matter for medication? Because amlodipine, losartan, and lisinopril act on different parts of the blood pressure system. Losartan and lisinopril both act on the renin-angiotensin-aldosterone system, the hormonal pathway that's more central to blood pressure in younger patients. Amlodipine works differently. It relaxes the smooth muscle in artery walls, which is why it can be very effective in older patients with stiffened arteries and isolated high systolic pressure. But, and this is the part that took me a long time to find explained clearly, none of these medications were designed to reverse arterial stiffness. They work around it, and when you have significant arterial stiffness, the wrong medication or the wrong dose doesn't just fail to help. It can create a new problem while solving the number on the screen. Here's the new problem it created for me. When you stand up from sitting or lying down, about half a liter of blood shifts down toward your legs from gravity. Your body has a reflex system, baroreceptors in your aorta and carotid arteries, that detects that pressure drop and fires a quick correction. speeds up the heart rate, tightens blood vessels, keeps your brain supplied with blood during the transition. In a younger person, this happens in under 10 seconds. You don't feel it. In an older person, especially one whose autonomic nervous system has slowed slightly with age, which is normal, this happens to everyone, that correction can take 30, 40, sometimes 60 seconds. During that window, your brain is running on less blood than it normally gets. That's when things go wrong. That's the wobble on the stairs. That's the moment in the kitchen where you grab the counter without really knowing why. That's the bad morning on the floor. Amlodipine dilates peripheral blood vessels. That's how it lowers blood pressure. It's also exactly the mechanism that can make postural drops more severe in people whose compensatory reflex is already slower than it used to be. Your medication is doing its job. Its job and your physiology are interacting in a way that produces instability. And because it looks like aging, everyone, including you, may file it under aging and move on. I moved on for 3 years. The thing that finally changed my understanding was a cardiologist who, during what I assumed would be another routine appointment, asked me to stand up. That was it. She asked me to stand up, waited 3 minutes, and measured my blood pressure again. It had dropped 29 points. She wrote that number down and looked at me and said, "This is why you're having trouble in the mornings. This isn't your inner ear. This is your medication and your autonomic system not working together correctly anymore." What she described has a name: orthostatic hypotension, and it's defined as a drop of more than 20 points in systolic pressure or more than 10 in diastolic within 3 minutes of standing. It affects somewhere between 20 and 30% of older adults on blood pressure medication, and in the vast majority of cases, it goes undetected because the blood pressure measurement at the appointment is taken sitting down, the one position where the problem doesn't show. I don't say any of this to alarm you. I say it because there are things you can do with this information, and they're not complicated. The first one is the most straightforward. Measure your blood pressure in 2 positions. Lie down or sit for 5 minutes. Measure. Stand up slowly. Wait 3 full minutes. Measure again. Do this 3 mornings in a row before you take your medication for the day. Write all 6 numbers down. If on any of those mornings your systolic pressure drops more than 20 points between sitting and standing, that's information your doctor needs. Just that information. You're not diagnosing yourself. You're documenting something that will take 45 seconds to interpret by someone who knows your history. And that documentation could change the conversation entirely. The second thing, and this one I find most people have genuinely never heard, is that when you take your blood pressure medication matters, not just that you take it. Blood pressure follows a daily rhythm. It drops at night during sleep. It rises sharply in the early morning hours, roughly between 6 and 9 a.m., when the body produces a surge of cortisol and the sympathetic nervous system ramps up. In a younger person with flexible arteries, that morning rise is absorbed fairly smoothly. In older arteries, that same rise hits harder. The morning hours are statistically the highest risk window for cardiovascular events in older adults with hypertension. That's established. It's not new information. What's less commonly translated into individual patient decisions is this. There's meaningful research, including a large chronotherapy study with over 19,000 patients, suggesting that in certain blood pressure profiles, shifting at least one antihypertensive medication to bedtime rather than morning improves how well the circadian blood pressure pattern is controlled and reduces cardiovascular risk measurably. Most older adults take all their blood pressure medication in the morning because that's when it was prescribed, and nobody ever revisited the timing. The timing isn't necessarily wrong. It's just that for some people, with some profiles, it isn't optimal either. And the only way to know which category you're in is a 24-hour blood pressure monitor, a device you wear for a day that measures your pressure every 20 or 30 minutes, including overnight. That study tells your doctor whether your pressure drops normally at night, whether it doesn't drop enough, or whether it actually rises. That information is what should determine the timing of your medication, not habit. The third piece that took me a long time to understand is the distinction between Losartan and Lisinopril. I was on Lisinopril for several years. I also had a dry cough for most of those years that I had attributed to various things: dust, a persistent mild allergy, getting older, dry air in the winter. I mentioned it at appointments. It was noted. Nobody connected it to my medication. ACE inhibitors, the family that includes lisinopril, cause a dry, persistent cough in roughly 15 to 20% of patients. It's more common in women and in people of certain ethnic backgrounds. It happens because the same enzyme pathway the drug blocks also controls the breakdown of a chemical called bradykinin, which can accumulate and irritate the airways. It's not dangerous, but it's not trivial either. In older adults, interrupted sleep from nighttime cough, or compensatory mouth breathing, or fatigue from months of low-grade throat irritation has real quality of life and health implications. Losartan and the drug family it belongs to, ARBs, work on the same blood pressure pathway at a different point in the chain and don't produce this cough. If you're on an ACE inhibitor and you have a cough that has no other clear explanation, that is a conversation worth specifically initiating with your doctor. Not because you know what the answer should be, but because you want to make sure that connection has been considered. The reason I'm being specific about initiating it is this. In a short appointment, with a cough that's been present for 2 years, the connection doesn't always get made spontaneously. You may need to be the one who says, "I want to specifically ask whether this cough could be my lisinopril." That sentence, said plainly, moves things forward. The fourth thing I want to raise is the question of the bottom number. When we talk about blood pressure, most attention goes to the top number, the systolic. High systolic is the risk factor that gets discussed. What's less commonly explained to patients is that in older adults, dropping the bottom number, the diastolic, too low, creates its own risk. The heart fills with blood during the pause between beats. That filling depends on there being enough diastolic pressure to push blood into the coronary arteries, the vessels that supply the heart muscle itself. When diastolic pressure drops below roughly 65 in an older adult, particularly one whose heart muscle has already developed some stiffness with age, which studies suggest is present in more than half of people over 75 with treated hypertension, the heart can start receiving less blood than it needs during that filling phase. That can manifest as chest tightness with mild exertion, fatigue, and in some cases as rhythm irregularities. This is called the J-curve phenomenon. It means that for older adults, there's a lower bound to how far down you want the diastolic to go, not just an upper bound. A diastolic of 58 in a 75-year-old is not the same clinical picture as a diastolic of 58 in a 50-year-old. But if the only number anyone's watching is the systolic, and the medication is successfully doing its job on the systolic, the diastolic can drift into problematic territory without anyone raising a flag. The practical thing you can do about this is the same as what I described before. Measure regularly, both positions, write it down, include the diastolic in what you report. If your diastolic is consistently below 65 in your home readings, mention that number specifically. Don't assume your doctor has seen it. If your clinic readings are always taken at the same time and in the same position, they may not reflect what's happening at 6:30 in the morning when you get up for water. The fifth piece, and in some ways the hardest to talk about, is the combination problem. Most people over 70 with hypertension are on more than one medication for it. 2 is common, 3 is not rare, and there are combinations that cardiologists and researchers have found to be counterproductive, not in theory, but in large clinical studies. The specific one I want to mention is taking both an ACE inhibitor like lisinopril and an ARB like losartan simultaneously. This combination was used for years based on a hypothesis that blocking the same hormonal system at 2 different points would offer greater protection than blocking it at one. Large trials, including one with over 25,000 patients, showed that the combination doesn't produce the expected additional benefit and does roughly double the risk of seriously low blood pressure, acute kidney deterioration, and dangerous elevations in potassium levels. That combination is now discouraged in major cardiology guidelines. But the research took time to filter through. Guidelines take time to reach every prescriber, and each appointment is 12 minutes. Some older adults are still on both, not because their doctor is careless, but because it was started by one specialist and was never reviewed when they saw a different specialist, and the complete medication list was never put on one table and looked at as a whole. This is the thing that I think the system isn't built to do naturally, and that you may need to do yourself. Make a list. Every medication, every supplement, everything you take occasionally. Bring it to your next appointment and ask specifically for a review of how those things interact. Not as a challenge to your doctor's judgment, as a contribution of information. You know what you take. They know how those things interact. That conversation needs both people. I want to say something before I finish, because I've been careful throughout this not to tell you to change anything. Everything I've described, the positional blood pressure, the timing of the dose, the distinction between the two drug classes, the diastolic number, the medication list review, all of it is information to bring to a conversation, not information to act on alone. The reason for that is real, not precautionary language. These medications interact with conditions and combinations that aren't visible without knowing your full history. A change that makes sense for one profile creates problems in another. I'm not a cardiologist, and even a cardiologist who doesn't know your complete picture can't safely advise on this. What you can do is go to your next appointment more prepared than you went to the last one. Measure your pressure in 2 positions. Write down the diastolic numbers. Bring the full medication list. Ask whether your current regimen has been reviewed recently, and if not, ask whether this is a good time to do that. Those questions are reasonable. Any doctor who takes a moment to think about them will recognize they're the right questions to be asking. 4 years ago, I was grabbing counters on bad mornings and calling it aging. Right now, I just walked 3 kilometers without thinking about it. I'm not telling you I found some answer that medicine missed. I'm telling you I had a conversation that medicine was equipped to have, but that nobody had gotten around to initiating. Sometimes that conversation just needs you to start it.